the multiple agnidal flow control technique in the curative brain AVM management. This is another way to skin the cat. So as you may know, the intranidal injection technique, so-called prolonged repetitive reflux and push, was developed by Saatchi in Ankara back in 1998. So after my partner developed this technique, actually, there was a lot of criticism on that because it was against many dogmas in the brain AVM management in the late 90s. Hopefully, the technique initially got a lot of refusal criticism, but hopefully it finally is described, it's well accepted, and it was disseminated to the world after good training programs performed worldwide in Ankara. And I'm glad we're discussing many, many ways of injection of eval right now. So since starting, the most important part of the technique has been the attitude of the operator, requiring utmost patience and taking responsibility to deal with such AVM with any technique, multi-plug, transvenous, or whatever. The most important thing is the attitude of the operator, I need to tell. But with the growing experience, we have learned that to be able to have effective and safe nidal penetration, this is all about controlling the flow in the nidus. The more you control the flow, the better you have a penetration. So in this standard technique of refluxing and pushing to the onyx, the other feeders always have a washout effect, which was pushing the liquid material to the vein. But when we realize that if we control the feeders, all feeders, so you have a stagnant flow, and basically you penetrate the nidus, and at the end you take the vein. So to be able to avoid that inadvertent arterial flux issue and also early reflux to venous side of the liquid agent, with its more effective nidal penetration, we have developed multiple nidal flow control technique, basically to create a closed flow control system around the nidus. So in such a right parietal AVM, three main feeders, and as you see here, the three detachable balloons. This was a case was done by Saatchi and Işlak in WNC 2021, and you control the flow in the nidus, and basically you penetrate the nidus, and this is actually a very safe technique in terms of arterial ischemia and early venous occlusion, because it provides a real control. Because washout from adult pedicles slows down or prevented, this technique lessens not only the amount of migrating to venous side, but also amount of reflux on microcatheter. And also it decreases the inadvertent arterial ischemia. The workflow of the technique is very similar to microsurgical management, actually. You turn around the malformation, you virtually dissect the AVM with 4D angiography, control the feeders, take down the needles, and occlude the vein, finally. So this is the workflow. First, flow control strategy needs to be defined, and 4D angiography for that is a great tool, provides the preoperative virtual dissection of the AVM, so you can understand the feeders, their courses, venous outlets, and nidal morphology. And after strategy is defined, and then you carry on with the technique with using multiple catheters or double lumen balloons. So this is a young female, and left temporal grade 3 malformation. This is how we show the workflow of the malformation. We always start with 4D angiography. We don't decide anything without 4D angiography anymore in terms of AVM embolization decision or any kind of indications. So it lets you understand the nidal morphology, if there is a hidden intranidal aneurysm, if there is a hidden venous stenosis. So you understand the course of feeders. You dissect the feeder, you dissect the feeders, and you dissect anatomy. Sometimes it takes an hour before the procedure. Then in this particular malformation, we found three main AVM pedicles. The posterior temporal of the left MCA and two separate pedicles comes from the left PCA. And we go there with three catheters. One of them is the balloon, which is in the high flow fistula part of the malformation. This can be three balloon, this can be three Apollos, and this is the simultaneous injections, contrast injections before the onyx injection starts. Then the penetration starts. As you see here, the penetration immediately starts from the balloon side, but with the Apollos, we first creating the plaques. And after we have the control, you exclusively send the material to the nidus of the malformation. As you see in these injections, you don't see an inadvertent the onyx material escaping to the venous side, because we have the stagnant flow in the nidus with 3 pedicles controlled. And control angiography during an iron injection showing no filling of the malformation. Other trick, we never rely on angiography, revealing the occlusion of the AVM as here, and continue to inject until we have an eggshell-like filling starts around the nidal cast. And in this particular patient, we injected more than 40 minutes more after the angio shows nothing. And these are one of these injection cycles. You see that the nidus is still being filled. This is very important. At the end, again, patience. And finally, after we decided to stop, and please note that the onyx cast is the nidus exclusively with occlusion of this vein in the vicinity of the nidus. So in our cast, you will see that because of the great flow control, the veins occluded at the very vicinity of the nidus. So this is the post-operative MR imaging, as always has to be shown. So in the relatively small AVMs, especially small grade 1, 2, and some select grade 3 and 4, multiple flow control technique offers the single stage cure, since we can control all feeders. And in this frontal bled malformation, again, 3 feeders, 2 of them was controlled with Apollo, and 1 of them was the scepter balloon. And after virtual dissection of the malformation, and look at this, the angio shows almost nothing in 11:58 a.m. But we don't rely on this. And we continue to inject. Multiple techniques offer the best intraoperative control in regard to how we occlude the nidus transarterial, since it creates almost perfect flow control, closed environment in operation field. But at the end, patience again. And this is 1:16. We almost injected another 78 minutes until we make this decision that this AVM is completely embo-closed. So don't rely on angiography. Here is a ruptured occipital malformation with a single draining vein, intranidal aneurysm, and in the single draining angiography showed a tight stenosis. Again, 4D was great in this case because we had the perfect working projection. This is the draining vein. This is the tight stenosis. So this AVM is an eloquent area. We have to have a complete nidal flow arrest, not only to send the material to the vein very inadvertently, and also control the ischemia in the eloquent area. So 2 double lumen balloons were used for 2 feeders. One of them is a mini scepter, other is the scepter, to control the intranidal flow, provide an exclusive nidal obturation, avoiding the inadvertent arterial, also early venous reflux. So eliminating the risk of long reflux plug need in the injected artery. So this technique providing and the prevention of ischemia, also flow control, prevention of venous ischemia. And this is immediately after embolization, and this is the diffusion MR showing no ischemia around the malformation. So the technique becomes very important again, especially if the AVM in a critical location fed by a critical artery that we should not be refluxing into it. In this particular hypocampal malformation, there are 3 feeders: anterior temporal, posterior temporal, and anterior choroidal beyond the choroidal point. So we had placed 3 Apollos from 3 catheters. This case was done before mini scepter era. The main reason for having Apollo placed in the nidus via anterior choroidal artery beyond the choroidal point is not to penetrate the nidus, but just to have a plug at the tip of the detachable catheter to have flow control and prevent retrograde inadvertent reflux to it. So if I have the mini scepter today, I was going to place the mini scepter here and inject. But in this particular case, we just had a reflux at the tip of the catheter in anterior choroidal and define a flow control. Then we penetrate the nidus. So then it keeps that anterior choroidal artery safe without any inadvertent arterial reflux during the injection. And this is the post-op diffusion MR with a small temporal ischemia, but not that clear anterior choroidal artery territory. This is the embolization, 2 years follow-up. And as you see the pre-op MR, there was edema of the large venous aneurysm. That edema is resolved and everything looks fine in this particular case. So this was a ruptured grade 4. The AVMs get bigger, so they have a bigger control. And in this particular malformation, again, 4D angiography did show a big impact, showing us that actually the AVM, not two draining vein, actually a single draining vein, because the second draining vein was just coming off proximal to the main draining vein, which is the stenotic at the junction of the lateral sinus. So when we see this information in this particular 4D angiography, then we realize that we need to have a perfect flow control. That's how we did it. So there are 4 catheters here, and as again, scepter and 3 Apollos from 4 main pedicles, and you see again a intranidal, exclusive intranidal cast and occlusion of the draining vein at the very vicinity of the nidus, and you don't see a lot of uncontrolled arterial refluxes. So whatever you do with single access, single venous injection or single arterial injection, you have absolutely no control when you do the injection, because in terms of having other arteries penetration. So in this technique, you create an environment that you control by yourself. And this is the post-embo diffusion MR showing a nice result after embo closure of the malformation. And this is the 1-year follow-up angiography of this grade 4 malformation. So another grade 4 left parietal. This patient not ruptured, but again, before the angiography showed multiple cluster-like the intranidal aneurysms, as you just gonna see here in this particular 4D angiography. So the indication is clear. This AVM needs to be tuned because there is a high risk of bleeding in this particular malformation. So the endovascular dissection was done. There were 4 main pedicles, 2 from MCA, 1 from ACA, but also another 4th pedicle from left posterior choroidal artery. However, this cannot be characterized with detachable catheter. So what we did is just we took a headway duo and catheterized and went there as distal as possible. And just to control the flow and also prevent the inadvertent arterial reflux to it, we did a proximal injection. Here is the injection. Then we went there with the multiple miniceptor balloons and Apollo with it from 3 main pedicles, and basically control the flow now completely. We have a flow arrest, and this is the cast of the onyx. As you see, this is the post-op angiography, and this is the post-op diffusion showing an extensive perinidal edema, but not ischemia, which is critically normal. This patient discharged neurologically intact, and this is the 6th week after the edema is resolved in this particular patient. And this is the 1-year follow-up of this patient. And another grade 4, and Sachi did in WLNC in 19 in Barcelona. And in this particular case, there were actually not 3, I think 4 Apollos and 1 miniceptor that they did with 3 people injection. And this particular technique needs a team approach. That's the main difference. It needs a team approach. The team needs to adjust and learn where these catheters are. And basically, this is not a one-man show as we used to do in this with this particular technique. So you control whole flow of the malformation and you cure the malformation. If the number of feeders are more than manageable for the simultaneous multiple injections, and then treatment can be staged to reduce the number of feeders so that the multiple nidal control can be done. In this particular grade 4 malformation, there were more feeders than to manage in single session. We realized that with the 4D angiography, And as the first part of the strategy, MCA feeder supplying the remote part of the nidus and one of the ACA feeder were occluded with some careful nidal penetration without venous penetration, just to prepare the AVM for the final curative multiplaque treatment. That's how we did it. This is after first session. And then the AVM is prepped for the final second curative session that can be done with 2 balloons and 2 Apollos, basically with the full flow arrest. And this is the post-embo and images showing the embo closure. This is the diffusion MR showing no ischemia in this particular malformation. And this is the 1-year follow-up angiography in this particular case. Another grade 4, 31-year-old male with a history of two bleeding episodes and had an embolization attempt elsewhere, then gamma knife that was failed 10 years ago, and he was presented to us with this large AV malformation, again, not manageable with single session multiple technique. In the first session, we aimed to cure this. The part of the intranidal aneurysm is in the PCA feeders after we did the virtual dissection. So basically close first the PCA part of the malformation. And this is the simultaneous right word and left internal carotid artery DSA after the first session, okay? So then the AVM is ready for the second and final curative multiplaque strategy. And it was done with 4 Apollos and 1 balloons with 5 catheters. We are able to reach to the PCA with the miniceptor, and from the ACA and MCA, we have 4 Apollos, and the triple access was made via the right radial and bilateral femoral arteries to control and do the action. An Apollo catheter in the nidus, the right ICA, the Apollo second, third, and fourth were placed at the nidus from the left ICA, left MCA. And finally, a miniceptor placed in the PCA field. And simultaneous catheter contrast injection, then following onyx and field injection together. Sometimes we use onyx and field to discriminate who is injecting from which catheter because the densities are different. And this is the post-op simultaneous angiography showing embo closure and also the diffusion MR showing no ischemia but perinidal edema and vasogenic edema. So according to the numbers this is our experience of the second decade of with onyx after 2011, 2012, and 158 patients treated with 59 patients treated with multiple technique. And these patients are the patients that we intend to cure. And these are the consecutive patients with multiple. And as you see, we have a pretty high complete closure rate, which is 92%. And we have complete 100% closure in grade 1, 2 to 3 malformations. And morbid mortalities, as you see, is around 6%. And we have only 1 patient had a post-op bleeding, which was particularly my personal mistake that I missed the AVM residue. And hopefully this patient had a decompressive surgery and he was okay in the 3-month control. About 64% of these patients were ruptured. Other 36 patients were unruptured, but weak points was shown in 4D angiography. We still clearly send many patients to gamma knife, and we still follow many patients. And this is at the 159 patients treated in the last almost 10 years. And you will say that this is selected patients. Of course, like in any series, there's a selection bias, but multiple technique is definitely changed, at least in our experience, comparing our previous first 10 years experience after Onyx between 98 to 2009, which was published in the Journal of Neurosurgery. We had much higher bleeding rates, especially in the grade 3 to 5. We have very high complication rates because of we don't have the detachable catheters and the other techniques. Thank you very much for your kind attendance. And I believe that in our experience, multiple agnidal flow control technique and also your experience may create a substantial change, but it certainly requires a team approach. Thank you very much.